Hi, my name is Brady Williams, and I'll be presenting a case study addressing urinary tract infection in a mother who is breastfeeding. So Betsy here is a 30-year-old mother of two, and she has made a same-day appointment with her PCP, a nurse practitioner. And on the phone, she noted that, it really feels like I've got a UTI, but I'm really still breastfeeding my toddler, and I don't want to take any toxic antibiotics. She's really pretty hesitant about the whole idea of taking antibiotics while breastfeeding. Her symptoms started 3 days ago. She noted that she had some slight burning pain with urination in the morning, and she's had a few UTIs before, and so thought this could be what is causing her pain. So she started drinking a couple glasses of cranberry juice a day, increasing her water intake. She thought, well, maybe that'll help my symptoms clear up. Excuse me. However, now she's noting that her pain, which was a 2 out of 10, is now a 7 out of 10 when she urinates. Just really excruciating burning pain. She's a high school teacher, doesn't have many opportunities to get up and go to the bathroom, and she tells you that she just almost didn't make it to the bathroom several times yesterday. And when she gets up to void, she finds, geez, I feel like my bladder's really distended, but then only a small, moderate amount of urine comes out. Um, so she's a little puzzled by that. She estimates she probably voided almost 10 times yesterday. In terms of medical history, Betsy isn't terribly complex. She had a left ACL repair when she was 19 due to a soccer injury, and she is gravida 2, para 2, was diagnosed with postpartum depression at age 29 after the birth of her son. She's allergic to sulfa drugs. When she was a child, she was prescribed sulfasalazole or Gantracin for an ear infection and broke out in a pretty serious full body rash. For medications, she takes sertraline 50 milligrams daily, which she was prescribed about a year ago for her postpartum depression, and the folic acid 400 micrograms daily. Her family history is significant for a history of hypertension and hyperlipidemia in her father, who is alive and age 62, and a history of major depressive disorder in her mother, who is also alive and is age 60. Her sister is 25 and has generalized anxiety disorder. In terms of her social history, Betsy lives with her husband. They've been married for 5 years, and she has two children, Max, her youngest, who's 18 months old, and Laurel, who's 4 years. She works as a high school social studies teacher. And Betsy and her husband are monogamous. They report to be monogamous. However, they are sexually active. And over the past month or so, there's been an increase in sexual activity. Betsy and her husband are thinking about getting pregnant, but sort of taking a we'll see what happens, throw things to the winds of fate approach. Um, she denies smoking or illicit drug use. In terms of alcohol, Betsy drinks 2 to 3 nights per week, just a glass of red wine after breastfeeding. And she has one large mug of coffee in the morning to get her through her school day. She is a very fit type. She plays indoor soccer twice a week and runs most other days. And her diet emphasizes whole foods, lean proteins, and she only eats red meat once a week. She knows she has that family history of hyperlipidemia. So she really lives a pretty healthy lifestyle. Now, when we sit down and talk to Betsy, her review of systems is really quite benign, all things considered, and most of the abnormalities are going to be found in her genitourinary system. So we won't linger on the other systems for too long. She denies fever, chills, fatigue, or any recent weight loss or gain. She notes that she's been getting poor sleep the last few nights, mainly just because she's been getting up to void so frequently. No changes in vision or hearing, no headache. Her skin she reports to be normal. Does not report any cardiovascular or respiratory issues. No nausea, vomiting, epigastric pain, changes in her stooling pattern. She does have some mild right ankle soreness because of a recent soccer injury, but denies any other joint pains, muscle aches or pains. And she denies any dizziness, recent fainting, pins, needles, numbness, lack of coordination, anything like that. She does note she's under a lot of stress raising 2 children and working full time, but denies being depressed, having a lack of energy, anhedonia, and really feels like the sertraline has worked for her postpartum depression. Now, for Betsy's genitourinary system, she notes profound dysuria with 7 out of 10 burning pain with urination, as well as increased frequency and urgency. She denies blood in her urine and denies any back or abdominal pain or tenderness. She denies having a history of any kidney stones and also denies vaginal discharge or malodorous secretions, which is helpful in ruling out some other things like PV or pelvic inflammatory disease, or at least maybe not considering them as high up on our differential. She does note that she's had increased incidence of sexual intercourse lately with her husband. She resumed menstruation about 6 months ago after she stopped breastfeeding quite as much, and she's had irregular menstrual periods since. The last one ended 14 days ago, and the last time she had intercourse was 6 days ago. When we examine Betsy, we find her sitting in the exam room. She's well groomed and no acute distress, but certainly some mild visible discomfort. Her head, ears, nose, throat, eyes are all within normal limits. No cervical or clavicular lymph nodes that we notice. Her skin is warm, dry, and intact. No rashes or other lesions. Everything in her cardiovascular system is grossly normal. Heart rate normal, normal S1, S2. She's got good pulses in all of her extremities. Her abdomen appears symmetrical. She has positive bowel sounds and no hepatosplenomegaly. Very importantly, there's no costovertebral angle tenderness. So in her back side, kind of above her kidneys, no tenderness there. But she does have moderate tenderness when we palpate her suprapubic region. Now notice that a pelvic exam was not performed. At this point, my suspicion for urinary tract infection is quite high, especially because she reports being monogamous and not having any vaginal discharge. So at this point in our workup, I would probably refrain from conducting a pelvic exam. If she were at a higher risk for pelvic inflammatory disease, perhaps that's the route that we would go. But for right now, I don't think it's necessary. Her vital signs are really quite normal. Blood pressure 132/78, heart rate 86, respirations 18, 99% on room air, and maybe just a mild temperature at 37.5 degrees centigrade. We run a urinalysis because we, again, have that high suspicion for UTI. It's positive for nitrates and leukocyte esterase. White blood cells are 12 per milliliter, and her urine is light yellow and clear. So we diagnosed Betsy with an uncomplicated UTI. What's the rationale? Well, her urine is positive for leukocyte esterase, which is an enzyme produced by white blood cells, and her WBC count in her urine is elevated. Generally, anything over 10 WBCs per milliliter is considered elevated. Notice that her urine was clear, yellow, no reports of it being terribly foul smelling. This is just kind of to show that you can't judge urine just by cloudiness and putrid smell, that it's very plausible to have a UTI and still have urine that looks totally normal. Our patient Betsy here, her urine is positive for nitrites. Now, other nephropathies can cause leukocyte esterase and white blood cells to increase, but nitrites is really indicative of infection with a type of bacteria that converts nitrate to nitrite. So this is E. coli, Klebsiella, Proteus, Citrobacter, Pseudomonas. It's very specific for these kind of infections. Otherwise, we usually expect urine to be free of nitrites. She's also symptomatic. She has dysuria, So we can be pretty confident that she has a UTI. Now, we're calling it uncomplicated, and that is cystitis, a bladder infection, because it hasn't ascended above the bladder. She has no costovertebral angle tenderness, no fever, no signs of systemic infection. At this point, it really appears located in the bladder and the urethra. So the pathophysiology of a urinary tract infection is that the urinary tract is usually sterile, and bacteria very frequently from the lower GI tract, and quite often this is E. coli, almost 90% of the time. It can also be Staph saprophyticus, Proteus, Enterococcus faecalis. These bacteria migrate or are forced towards the periurethral area. They ascend the urethra and invade the bladder mucosa. Now, once here, they secrete endotoxins, which actually decrease the peristaltic activity in the urethra, which allows them to adhere more easily to the urothelium. Cytokines are generated, which increases leukocytes and lymphocytes in the area, which contributes to the painful inflammatory process, causing the discomfort. Now, risk factors for urinary tract infection include just being female due to having a shorter urethra. It's less distance that the bacteria have to cover before they can get into the bladder. Prior antibiotic use can alter vaginal flora, decreasing levels of lactobacillus, which often compete against more pathogenic organisms. An increase in urine pH, sometimes due to a low protein diet, can also encourage bacterial growth because acidic pH tends to be bacteriostatic and sometimes bactericidal. Intercourse can certainly bring about a UTI, especially if there's no void postcoital. And the use of spermicides, IUDs, and unlubricated condoms are also associated with higher risk of UTI. Also, naturally, catheterization or instrumentation of the bladder, anything where you're going from the outside to the inside of the bladder, can introduce pathogenic organisms. Immunocompromised patients, pregnant patients, so those patients that have difficulty voiding completely are all at increased risk. If there's any residual urine, that can be almost a reservoir for bacteria to collect in. Our treatment goals for Betsy are going to be both to resolve the infection and to provide symptomatic relief. We need to resolve the infection because there's a chance it could progress to pyelonephritis, possibly even a systemic infection, which would be even more dangerous. Now, the likelihood of this is quite rare in young, healthy individuals such as Betsy, possibly as little as 2%, but this risk still exists and needs to be addressed. Symptomatic relief will come as the infection starts to clear. However, there are a few things that we can do to manage her pain and frequency and urgency in the meantime. Now, there's 5 additional factors that I think we should take into consideration before prescribing a particular antibiotic to Betsy. First, efficacy and stewardship. Is the treatment likely to work? And if it doesn't work, is it likely to contribute to an already existing antibiotic resistance problem? Secondly, is whatever antibiotic we choose going to be safe for an 18-month-old? Does it cross into the breast milk? And if it does, what are the repercussions? Third, we can't entirely rule out pregnancy with Betsy, given when her last menstrual period was and when she most recently had sexual intercourse. So we should probably at least think about whether these antibiotics that we're going to be prescribing are safe in pregnancy. Fourth, as always, we need to make sure the antibiotic is compatible with Betsy's allergies and the medications that she's taking. And finally, we should consider the cost of our various therapeutic alternatives. So the next thing we need to do is figure out what kind of antimicrobial treatment is going to work best for Betsy. Now, do we need to culture the urine that we collected earlier to find that out? Well, the American College of Obstetricians and Gynecologists says no. in a young, healthy person like Betsy with an uncomplicated UTI, we can just go ahead and treat empirically, especially considering the most likely culprit is indeed E. coli. So the first-line agents, according to the Infectious Disease Society, are Bactrim, and that's trimethoprim and sulfamethoxazole combined. It's going to be 1 tab by mouth twice a day times 3 days. Our second choice is NITROFURANTOIN, and the macrobid formulation comes as the monohydrate, which is kind of a powder, and the macrocrystals, which dissolve slower. Those are combined into one capsule. That's going to be 100 milligrams PO twice a day times 5 days. And then we have fosfomycin, which is great in some ways. It is a 1-dose option, so it's great for patient adherence. It's a powder that reconstitutes with 3 to 4 ounces of water. Now we're going to apply those patient-specific considerations that we discussed earlier to figure out which one to choose. So first of all, Bactrim, if you notice that sulfa prefix in sulfamethoxazole, means that we probably want to avoid it because the patient has a sulfa allergy. It sounds like her reaction as a child was pretty significant, so we're probably going to automatically eliminate Bactrim. Additionally, some communities have high rates of resistance to Bactrim among E. coli strains. So the Infectious Disease Society recommends alternative treatment if you can get away with it. It's not contraindicated for breastfeeding, but does have an increased risk of possible birth defects if it's taken in the first trimester of pregnancy. And since there is that outside possibility that Betsy could be pregnant, we're going to avoid Bactrim for now. Our next option, fosfomycin. Yes, it's great. It's 1 dose. However, it's really pretty expensive at $80 a course, and it's not always carried by all pharmacies. So by process of elimination here, we're going to settle on the macrobid, the nitrofurantoin. Nitrofurantoin works by being bactericidal in the urine at therapeutic levels. So this drug is really only for cystitis, not for systemic infections, not for pyelonephritis. In fact, if pyelonephritis is suspected, this is a very poor and absolutely contraindicated choice for an antibiotic. It works via a multifactorial mechanism. Bacterial flavoproteins reduce nitrofurantoin to various intermediates, which alter bacterial ribosomal proteins. These, in turn, change protein, DNA, and RNA synthesis within the bacteria, and also impair their ability to synthesize cell walls. It has very good efficacy against E. coli and Staph erythritidis, and resistance is very rare. In terms of pharmacokinetics, the macrobid form of nitrofurantoin is composed of 25% macrocrystals, which dissolve slower in the gut and help prevent GI upset. And the other 75% of the capsule is a nitrofurantoin monohydrate powder that forms a gel matrix with gastric and intestinal fluids and releases over time. Now, the drug is highly bioavailable, and this is only increased with food. So it's a good idea to instruct your patient to take this with a little snack, food, milk, etc. It's very well absorbed. About 2/3 of the metabolism happens in the liver, metabolizes it to inactive metabolites, and approximately 1/3 is filtered by the kidneys. Unchanged, it concentrates in the urine and helps kill the bacteria. Now, those with poor kidney function, say creatinine clearance less than 60 milliliters per minute, are at a little bit of risk because not only do serum concentrations of nitrofurantoin tend to accumulate, the amount that actually gets into the bladder decreases, so it might not be as effective for these patients. Now, nitrofurantoin has very poor tissue penetration, which is great in one way because it helps contribute to its very small side effect profile, but also, again, as mentioned earlier, means it's really only for bladder infections, is not going to help an infection in any other tissue. The plasma And this graphic right here is just to reinforce that nitrofurantoin or macrobid works at the bladder, not above the bladder. So that's, as clinicians, something to really reinforce and think about. So we settled on nitrofurantoin almost through the process of elimination. Now let's double check to make sure it's really the right choice by applying those 5 criteria. Is it efficacious? Well, it's highly effective against E. coli, and this antibiogram from Maine Medical Center in 2016 shows E. coli to be 98% susceptible to nitrofurantoin. Now, this is in comparison to Bactrim, which is only 82% susceptible. And remember those ISD guidelines, which state if this resistance rate is 20% or greater, you might really want to reconsider using Bactrim. So it's only 18% in this case, but still close enough that using nitrofurantoin is probably the responsible decision from a stewardship point of view, because Bactrim may actually be selecting for more resistance. In terms of lactation, there's 2 very useful resources. There's the Sanford Guide, which gives you some quick hits in terms of what's safe or unsafe during lactation. And then the National Institutes of Health have a site called LactMed, which synthesizes current research on lactation and gives a narrative analysis of whether a certain drug is contraindicated or not if the mother is breastfeeding. And with respect to nitrofurantoin, they suggest avoiding in infants less than 1 month of age, or those with a glucose 6-phosphate deficiency due to a risk of hemolysis. So this 18-month-old should be fine. In terms of pregnancy, it's pregnancy class B, so essentially meaning there's no real proof that it does any harm to the fetus. We don't have any great human studies saying that it's absolutely safe, but there's no real indications of harm. We do want to avoid macrobid or nitrofurantoin at term due to its possibility of causing hemolytic anemia in the fetus or the newborn. And there's no contraindications in terms of allergies. One thing we should be aware of is that uricosuric drugs for gout, such as sulfonpyrazone and probenecid, can actually increase serum levels of macrobid and therefore decrease its efficacy, less drug getting into the bladder. And also certain live vaccines, one for cholera, one for tuberculosis, you want to avoid just because the vaccines won't work as well if you're also administering nitrofurantoin. Now, the cost is a little bit more than Bactrim, about 3 times as more, but fortunately that jump is only from $6 to $20, and it's a lot less costly than fosfomycin. So it's really pretty reasonable for a 5-day course, $20. Adverse reactions that drug can cause, the most common one is just going to be nausea, and that can be partially ameliorated by administering it with food or milk. The pulmonary reaction here is actually thought to be a type of hypersensitivity reaction. It's rare, but quite serious. Patients can present with dyspnea, chest pain, pulmonary infiltrates, cough, chills. You certainly want to discontinue therapy if the patient experiences any of those. It can cause hemolytic anemia in those with G6PD. And since it is metabolized by the liver, there's a chance of hepatotoxicity and also a chance of irreversible, in some cases, peripheral neuropathy. And these are very, very rare side effects, and it's much more likely to occur in patients with kidney compromise where the drug is accumulating more in the serum, and for those who've been on long-term prophylactic therapy with nitrofurantoin. So I'm not quite as worried about these side effects for Betsy here. And then, although it certainly isn't a main culprit, there's always the risk when you're altering the gut flora of C. diff colitis. So I want to make sure that Betsy knows that, sure, some loose stools might be expected while taking this antibiotic and shortly after, but if she's having 2, 3, 4, 5 loose stools a day for several days, then she should certainly return to be reevaluated. We're going to instruct Betsy to take her entire 5-day course of Macrobid, and to finish the course, even if she starts feeling better within those 5 days. We'll instruct her to take the PM dose after breastfeeding. That way she can breastfeed with very, very low serum levels in her blood. And we're going to also instruct her to take it with food or milk. This decreases GI upset and increases bioavailability of the drug. And it's very important that she separate consumption of the drug with consumption of any antacids, especially those with magnesium trisilicate, by at least an hour. What can happen is the nitrofurantoin gets adsorbed onto the magnesium trisilicate, and the patient, Betsy, absorbs less. We're really going to reinforce with her that the risks in taking this antibiotic in breastfeeding and even her very unlikely but possible pregnancy are very small. The toddler may experience some diarrhea as a result, and not a great chance of this happening, but that might be expected. Brown-colored urine may occur with nitrofurantoin. This is an expected, might be somewhat unsurprising effect. She can take a probiotic if desired. Nitrofurantoin actually has a lot less of an effect on gut flora and vaginal flora than some other antibiotics, but if she feels like taking an antibiotic, she can go ahead. And we'll just alert her that if she experiences any anaphylactic like reactions, facial swelling, difficulty breathing, certainly head to the emergency department. And if she has some signs of this pulmonary reaction, this cough, mild chest pain, shortness of breath, call the office, stop taking the medication, and we can try to work out putting her on a different antibiotic. She should expect some relief within 48 hours. Now, if there's no improvement by that 3rd day, she should call the office and come back in for reevaluation. Or if she gets fever, chills, lethargy, flank pain, that might be a sign that the infection has ascended within the urinary tract, and she really it's very likely going to need IV antibiotics. So what else can we reinforce with Betsy? Well, we can offer her phenazopyridine, 100 to 200 milligrams 3 times a day with meals. This is a bladder analgesic, but we don't really want her on it for more than 2 days, since we might mask the symptoms of the infection actually getting worse. We'll make sure she's drinking sufficient water, at least 8 cups a day. Make sure she's flushing out her urinary tract. Warm compresses to the lower abdomen for comfort. Avoid caffeine and alcohol, which can be bladder irritants. Alcohol isn't actually necessarily contraindicated with nitrofurantoin, but it's not going to help her bladder symptoms. In terms of prevention, we want her to stay well hydrated, intake sufficient protein, make sure she's voiding after sex. Hopefully avoid diaphragm, spermicides, and other products that can irritate the urethra. Cranberry juice, the jury's sort of still out on that. It may prevent some of the bacterial fimbriae from sticking and latching on to the urethra and the bladder. It's not proven to have great efficacy, but if she likes cranberry juice, she can go ahead and do that. And one last thing, before I let her leave, I did notice in researching the suitability of various antibiotics in a possibly pregnant woman that sertraline is pregnancy class C. So we probably want to have a discussion about whether she might be ready to taper that, or perhaps she can try to use a barrier method of contraception in the meantime, and then start thinking about whether she wants to try to get pregnant again. So unfortunately, 3 days later, Betsy comes back. She got some mild symptomatic relief from the phenazopyridine, but now her UTI is worse than ever. The pain is back. She still has urgency, still has frequency. Fortunately, no flank or costovertebral angle tenderness. But what we really need to do is do another urine, and this time we will absolutely do a culture and run sensitivities to see what organism we're dealing with and what we can treat it with. Perhaps it's another gram-negative bacteria like Proteus, Pseudomonas, or perhaps a rare resistant strain of E. coli. But what we're going to have to do is change our empiric treatment to a second-line agent, possibly a fluoroquinolone or a beta-lactam with a beta-lactamase inhibitor like Augmentin. And once those CNS results come back, we will treat specifically according to what that organism is sensitive to. Now, note, this changes the whole conversation about pregnancy and lactation, and as providers, we need to go back and do our diligent research to make sure our next choice is safe for Betsy. Thank you for listening to the presentation. And finally, here are some references that were consulted in the creation of this presentation.